Good afternoon, everyone. Thank you so much for being with us. We'd like to start today on the solemn, somber note, and I've asked Naomi Wyndham to share a statement from her organization to start us today. Naomi?
Yeah. Good afternoon. We would like to make space to acknowledge the loss to our community with the killing of Daunte Wright by police in Brooklyn Center on April 11th, 2021. We recognize that our Black and Brown colleagues, our patients, and the broader community are emotionally burdened by these traumatic events in deeper and more persistent ways. We want to normalize that it is okay to take space to grieve, to reflect, and to support one another as needed during this time, along with the many layers of tragedy in our community with the Derek Chauvin trial happening simultaneously. We would like to make note that throughout our presentation today, that the majority of our program serves Black and Brown people who look like George Floyd and Daunte Wright. We are here to serve them, and that means sitting in collective grief with the community.
Thank you so much, Naomi. So we welcome you all here to the Council's second webinar in a series of 3, Increasing Access to COVID-19 Vaccines Among Homeless Populations, Successful Partnerships. And today we will be featuring the partnership among a number of community entities in Minnesota. Just a few acknowledgements and disclaimers. This is supported by HRSA, but the content is ours. And we are very fortunate enough to be joined by a number of amazing professionals from across Minnesota. They are speaking about their own experience and their information that they have from their work. So today's panelists, we'll start with Blair Harrison, Senior Advisor on Health, Homelessness, and Housing for the Minnesota Department of Health, and her colleague Josh Leopold, Public Health Planner at Minnesota Department of Health. You'll hear again from Naomi Wyndham, Family Nurse Practitioner and Leader of Justice, Equity, Diversity, and Inclusion at HCH, Healthcare for the Homeless in Hennepin County. Veronica Jackson, Community Health Worker for Hennepin County. And John Adams, Program Director at Harbor Light Shelter. I am Katie Lee. I am a member of the policy team at the National Healthcare for the Homeless Council. I am a COVID-19 project manager, and I've had the opportunity to learn from these amazing individuals on the work that they are doing. Some goals and agenda for today's webinar. I want you to learn about the collaboration within Minnesota that fosters innovative and timely responses to meeting the needs of people experiencing homelessness during the pandemic. Discuss the use of data to inform the decision to prioritize people experiencing homelessness for critical interventions, including early access to COVID-19 vaccines. Understand how to collect data on equity and use it to transform equity work. Learn how to integrate staff in equity work across agencies. Discuss the role of community health worker in vaccine engagement. And then as we are able to address as many of your questions and comments as possible. So please flood that chat box as you learn from your colleagues. I just know you're going to have so many wonderful questions about the amazing work that they are doing. So I'm going to start by turning it over to Blair and Josh.
Good afternoon, everyone. I'm going to wave and say hello, and then I'm going to turn my camera off so you don't get car sick. I'm traveling right now, and it's really bouncy. I want to start the presentation from just the state perspective by sharing the statement. Some of you have seen this before, but just a reminder as we talk about different outcomes and experiences in the work. that we know that both homelessness and COVID have disproportionately impacted communities of color and Indigenous communities. And those impacts aren't the consequence of individual choices or decisions. They're a reflection of racism and the structural violence that exist in housing, healthcare policies, all of our systems. And those systems and that violence is by design. So it's all of our work to dismantle that and to be anti-racist in our response work. I want to just start off also by saying we're more grateful than ever for our partners as we do this work to urgently address the structural violence impacting housing, COVID, and vaccine outcomes and the intersection of all of those things. So thank you for being here today. We're really looking forward to the discussion and from shared learning. All right, Katie, we can go to the next slide. So I'm going to give just a quick overview of vaccination in Minnesota broadly, and then a situation update on our COVID-19 cases and the impact on those experiencing homelessness since April of last year in the state. So when we look at most recent Minnesota data, about 27% of those in Minnesota have a complete series, about 42% have received a single dose, and that's statewide, so not specific to our homeless population in the state. One important thing to point out when we look at the statewide data is that there are striking differences by race, and important to frame that race and that when we look at the differences by race, we should be thinking of race as a proxy for racism. There's not a biological or physiological reason that there should be disproportionate impact levels of vaccination, but certainly racism in healthcare service delivery and access and differential experiences of trauma with medical research, public health, healthcare, all of those things contribute to the differences that I'm about to share with you for Minnesota's statewide vaccination rates. So while nearly 5% of Minnesota's population identifies as Hispanic, Hispanic individuals currently represent only about 1.9% of those fully vaccinated in the state. Black and African American individuals are 6% of Minnesota's total population, and about 3.4% of those fully vaccinated in the state. Asian and Pacific Islander individuals are 5% of Minnesota's population and 3.2% of those fully vaccinated. And while the white population of Minnesota is 82% of the state census, they represent 92% of those who are fully vaccinated. So we clearly have some unacceptable disparities occurring at the state level when we look broadly at our vaccination rollout so far. One thing worth noting is the American Indian population of Minnesota is 1% of our state census and represent 1% of those fully vaccinated, which I think is a testament to the tremendous work of the 11 tribal nations and urban Indian organizations in our state. Wanted to highlight that. So that's the overview of the statewide data. We will get into, Josh will talk a little bit about how we're tracking the work we're doing vaccinating populations experiencing homelessness in the state. And then I know our partners from Healthcare for the Homeless and Harbor Light will talk about that as well in more detail too. All right, Katie, next slide, please. So just to provide a little bit of context as we move into specifically discussing our efforts among those experiencing homelessness, wanted to ground everyone in just some of our data over time. Again, this is from the statewide level, looking at cases over time. So you can see the stacked bars, the blue part is showing those who are identified as living in shelter at the time of their COVID diagnosis. The green part of the stacked bar are those individuals who are unsheltered, and then the gray are staff and volunteers. So you can see Minnesota surged like much of the country in November. One thing that I'm happy to share now that even though our case numbers are rising in Minnesota, B117 is the dominant strain. We're seeing just an increase in outbreaks and cases, but we've not seen that spill over into our homeless service settings. And we believe a lot of that is due to the incredible work that's been done by our local partners in vaccinating early and doing incredible education and providing access to those. We've had one recent larger outbreak in a congregate setting, and unfortunately it was a setting that was not yet vaccinated. And so there were a larger number of people who were susceptible to infection. But otherwise, the numbers in our homeless service settings have remained pretty steady over the last few weeks, while the rest of the state has started on an upward trend. All right, Katie, thank you. And so this data, I know we've also shared this during a previous presentation, but we have started to do a more in-depth analysis. That work is still underway, but I did want to share just some of our additional preliminary findings as we dig into hospitalization and again, just the importance of this data. So the data that I'm about to share was really one of the big levers that we pulled in the state of Minnesota to prioritize people experiencing homelessness early in our vaccine efforts. The other major factor I think that helped us in that prioritization were the strong partnerships with trusted homeless service providers and healthcare teams that we had worked with over the last year. And Josh will talk more about that in his section, but to just quickly share a little bit more about the hospitalization data. So you can see, looking at the screen, about 28% of COVID-19 cases among people experiencing homelessness were hospitalized, compared to just 5% of the overall population. And we also see a higher level of ICU utilization. The additional analysis that we've done is to do some regression analyses controlling for age and gender. And when we've done those adjusted analysis, the relative risk of hospitalization for those who were sheltered at the time of their diagnosis is about 4.35 compared to those in private residence. And when we look at those who are unsheltered at the time of diagnosis, their relative risk of hospitalization is about 11 times higher. So some really statistically significant and clinically relevant differences in these groups. And then just this last little bit, this is just another new preliminary sub-analysis finding that I wanted to share. So when we looked at the specific living setting types within our homeless population, when we compare other settings to those who are living in shelter, we found that those that were unsheltered doubled up, and in our COVID protective hotel programs, had a statistically significant increase of about 2 times as likely of being hospitalized. And there we can get into lots of detail and discussion, I know, about this information, but I did just want to share it again. I think this type of data can be really helpful in working with our partners to prioritize the population for the vaccine work that's happening. So with that, I will turn it over to Josh to just get into some more details about the state's work overall.
Okay, thank you, Blair. So when we first realized, kind of started planning for the vaccine effort at the state level, it really began with kind of getting our arms around what our scope was and which types of settings we would be focused on, trying to make sure that they got offered vaccine as part of our group, and which were either out of scope or being covered by a different part of the state's vaccine response. So in terms of so we had to pull together a group with kind of diverse representation from different state agencies, and we met daily to really figure this out. So in terms of what was in scope, staff working in the isolation hotels for people who are COVID positive were in scope, and they were in scope by virtue of kind of working in a COVID positive environment, similar to other COVID environments, not specifically for people experiencing homelessness. And then really based on the strength of the data that Blair just presented, we were able to get people who are unsheltered and homeless, street outreach teams, drop-in centers, as kind of one of the higher priority, top priority within the homeless settings, as well as the hotels for the high-risk population. So, because that was where, Minnesota, as with a lot of the other parts of the country, it's really amazing how quickly the homeless service providers moved to get higher risk people out of congregate shelter and into hotel settings. And so that was where a lot of the more vulnerable people, medically vulnerable people were living. So those sites were prioritized for vaccine, along with congregate shelters, where just by virtue of having shared bathrooms, having shared eating spaces and living spaces, there's just a higher risk of transmission. And then for a little bit further down on the list of in-scope settings were site-based permanent supportive housing and transitional housing. In Minnesota, we have board and lodges, which is kind of a catch-all term for any kind of residential setting. I think it's like any residential setting with like 5 or more people in shared spaces. And so that is very broad and can include a real continuum of different levels of services and level of congregate versus kind of apartment style settings, as well as the DOC licensed halfway houses. And then we originally hadn't included the unlicensed sober homes, but as we kind of expanded eligibility and moved through more of the facilities on our list, we have also been working with some of the unlicensed sober homes to get vaccine events scheduled for them. In terms of what we did not include in our scope, people in doubled up housing situations, so kind of multiple households living within one apartment. This was a tough one to exclude because a lot of the data shows that this is the population that maybe is at one of the highest risk for COVID, but we didn't really just have a mechanism for identifying and reaching those types of situations and getting vaccine to them. So unfortunately, we weren't able to include those, as well as scattered site supportive housing. So those are people living kind of in their own apartments with a voucher and with services. And we decided not to include those just because we felt like their housing situation didn't put them at any increased risk for COVID relative to other people, living in their own apartments. Although they could be prioritized by virtue of, age or medical vulnerability. And then residential treatment facilities were out of scope because that was covered by a different working group at the state. Okay, next slide. So in terms of how we track data, we kind of broke it out into 3 different categories. So we track data on doses, data on settings, and data on people. So in terms of doses, took a little while to get there, but we ended up with we have a kind of a standing allocation of 1,200 doses, 1,200 first doses per week for people experiencing homelessness and people in congregate settings and staff. And we track very carefully because we have to, which vaccinators, so the vaccinator, either state contracted vaccinators or local public health agencies are receiving those doses each week. And we have a spreadsheet that tracks that. It's more difficult to track, so we know kind of who's getting the doses. It's a little bit more difficult to track how those doses are getting administered for a couple of reasons. One is that the state immunization database, the Minnesota Immunization Information Connection, has pretty minimal data collection standards. It's got like name, date of birth. Those are that's the main information that it collects. So it's not always easy to tell when a dose is administered, if it was administered to somebody experiencing homelessness or someone in a congregate setting. And then, a lot of the vaccinators, they're getting doses through our allocation, but then they're also getting doses for a lot of other purposes. So it's not as always, we can tell you how many doses we've allocated, but it's harder to tell how many doses we've actually used for our settings. So then in terms of information on settings, for the facilities that we covered through our state contractors, we sent out a survey to assess, using REDCap to assess whether they'd already gotten vaccinated through some other channel. If not, whether their people could travel to a vaccine clinic elsewhere, or if they needed somebody to come to them, and then whether they had kind of a common area that could be used for a vaccine clinic, the level of kind of congregate living arrangements, and to assess just like the level of risk within the facility, and then some information about their preferences for scheduling a vaccine clinic. So that was our original survey, and then kind of later on, we communicated to all the facilities within our settings about a different statewide red cap survey that any kind of residential facility with like more than 50 people could use. So that includes like long-term care, assisted living, public housing, to schedule a vaccine clinic for their facility. So those were the two main sources of information on settings. And then in terms of understanding people and which people have gotten vaccinated and vaccine, rates by, geography or race or ethnicity or other factors, we're partnering with the Hennepin Healthcare Research Institute, and they're in the middle of doing a data merge between the homeless management information systems data, the MIC, which is the statewide immunization database, and electronic health records. And that's going to allow us to have data that's going to be updated on a weekly basis to tell us for everybody experiencing homelessness within the last year or within the last 3 months that's in the HMIS, what their vaccination rates are, and then we'll use the electronic health record data so that we can kind of split that out more finely based on different factors or medical conditions. And this is all de-identified, so we're not exposing anyone's personally identifying information. Okay, next slide. So this shows the breakdown of which of the facilities were vaccinated by local public health agencies and which of the facilities were vaccinated through our state contracts. So we executed contracts at the state with 3 different healthcare systems to be kind of the safety net for facilities that weren't being covered by local public health. And then we did outreach to all the different local public health agencies, and we sent them our list of, these are all the facilities that we have covered in our settings. Do you prefer to vaccinate them on your own, or would you like the help with the state contractors? And so this map shows kind of the distribution of where local public health was taking the lead and where our contractors were working. And as you can see, most of Greater Minnesota, the local public health agencies opted to do it themselves, and which was great. And then in the metro area, it was more of a mix between our state contractors and the local public health agencies. Okay, next slide. Okay, so this slide has a lot going on in it, but it kind of just tells you of the facilities that were covered by our state contractors, what percent of those facilities have gotten vaccinated. So overall, of the roughly 900 facilities that were on our list, a little bit over half were kind of in the state contractor covered areas. And as of yesterday, I think that 76% of those settings that we're tracking have have been offered vaccine in some way or another. The ones that are remaining are kind of the ones that are a little bit lighter shaded in the metro area. And that tends to be just the sheer volume of the number of facilities, and often kind of smaller residential facilities. It just takes a little bit longer to get to all of those facilities. But still, we're very happy with the progress we've been making on that. Okay, and then the next one. So just in terms of what the lessons learned from doing this over the last few months, the importance of having a good list has been really instrumental. I feel like a lot of the early work was just kind of juggling many different lists of, shelters, supportive housing providers, board and lodges, halfway homes. And at least for me, I felt a lot less stressed when I kind of felt like we had a good global picture of all the settings that we were covering, and then being able to track, kind of just work our way sequentially down the list and check off facilities as they were getting vaccine. The importance of having clear roles and frequent communication has been really essential. So, in some ways it's been glad that vaccine has come at the end of this process, because we've developed these really strong relationships with local public health and with our contractors. And so everybody kind of was used to working with each other and knew about there were clear roles, and that's made everything a lot easier. Another is giving people lots of chances and options for how to get the vaccine. One of the things that we've heard from our local partners is that every time they show up to do second doses, they get more and more people showing up for first doses that are kind of their original hesitation about the vaccine has faded a little bit as they've seen more of their peers and family members getting vaccinated and seeing the beneficial effects of that. And then finally, one of the constant struggles we've had is the pressure that we're getting at the state level to use all the vaccine as quickly as possible. So the guidance is to you use 90% of doses within 3 days and all of your doses within 7 days. I'm trying to balance that with some of the special considerations working in homeless encampments and shelters and other places where it's very hard to know precisely how many doses you're going to go through each time you go out, and it just kind of takes more time and more care than sometimes that speed goal on its own would warrant. So finally, in terms of next steps, we have the Minnesota Department of Health has these vaccine buses, which I'll show you a picture of in a minute, that are going to be rolling out next week to do more of the on-site vaccine clinics. Originally, they've got some encampment scheduled, and then some of the larger kind of high-rise apartment buildings. We'll be doing a follow-up survey of all of our facilities just to learn more about their kind of ongoing vaccine needs and their experiences during this process. And then we're also kind of working with our local partners on what kind of vaccine maintenance looks like. So instead moving away from these kind of bigger vaccine clinics and more kind of how we integrate the COVID vaccine into regular care, similar to what we do with flu vaccine and others. And then the last slide is just a picture of what these vaccine buses are. So they're retrofitted city buses, and then you can see the outside and the inside of the buses. All right, thank you very much.
Thank you, Josh and Blair. We'll turn it over to Naomi.
All right, thank you. My name is Naomi Wyndham. I am a family nurse practitioner. I work for Healthcare for the Homeless in Hennepin County. I work specifically in one of our physical clinics. I also do COVID isolation care. And I am the clinical lead for Justice, Equity, Diversity, and Inclusion for Healthcare for the Homeless. So to start us off, just a little bit about our Healthcare for the Homeless program in Hennepin County. So we are a federally qualified healthcare center specifically located in Hennepin County proper in Minnesota, but also as part of the Hennepin County system. Hennepin County encompasses Minneapolis and surrounding suburban areas, including Brooklyn Center, Brooklyn Park, St. Louis Park, just to name a few. We have 5 physical medical clinics. And so these clinics are located within our shelters and within drop-in centers in Hennepin County. We are currently supporting 3 high-risk hotels that are housing people who are at higher risk for severe COVID morbidity and mortality due to COVID. And then we have 1 COVID isolation hotel that we are also supporting. We have a very robust street outreach team encompassing providers, nurses, social workers, community health workers, and supports that go into the community, into encampments and places where the unsheltered population is residing. And then we have a mental health team that emphasizes low barrier care. And so they provide a really flexible mental health model of care. A little bit about our COVID vaccination process so far. So we have utilized a pod model in order to distribute our vaccines up until this point. So starting at the beginning of January. And our pod model has a really high emphasis on education of our own staff, of patients, and then of the staff that support our shelter system. And so what this means is essentially we would go to a clinic or I'm sorry, my doorbell is ringing. We would go to a clinic or a drop-in center, and we would set up there and be able to vaccinate people who were either residing there or were able to get to that site. And so prior to this, we would do a number of interventions surrounding education. So we provided time for our staff to actually receive education on the vaccines that we were preparing to distribute. What does the research say? How is equity emphasized throughout the research? What are some of the questions that our patients might ask? And then we were able to go to our patients and really encourage our staff to provide education on vaccines and ask questions of our patients about vaccines at every medical visit that they would come into clinic for, and to do outreach surrounding vaccines to our homeless population. We also encouraged our staff to do outreach to the shelter staff. We found that a lot of our frontline shelter staff have very similar hesitancies as some of our patients. And sometimes those staff could be really good advocates for vaccination as well, because they have oftentimes really strong relationships with the community that we serve, and also have often some experience with homelessness or some cultural similarities to the population that we serve. So up until this point, we have given 930 COVID vaccinations to people experiencing homelessness within Hennepin County through our specific efforts. Some important factors that I'd like to emphasize. We've had the most difficulty reaching the unsheltered population, teens and families, and for different reasons, I think. I think all of our patients are complex. These groups specifically, there's been a considerable amount of hesitancy within the unsheltered population. It's been difficult to utilize a pod model of vaccinations with this population because of vaccine storage issues, needing to go to multiple different sites, and relying, not being able to utilize the relationships that we've formed in the best way as we are distributing vaccinations. Teens and families, we have found that there just needs to be, the emphasis on relationships is just huge. And there's been some significant barriers in that, partially related to COVID pandemic and how we do care because of the pandemic. Second doses of Moderna have been a challenge. Getting people back, part of this challenge is due to transiency of our population. Then within our data, we have seen Black and Indigenous populations underrepresented in our vaccine efforts, and white populations overrepresented in our vaccine efforts. And the statement I would like to make about this is that it is easy to think about homelessness as in and of itself an underrepresented group, which it is, and a group where we are working with people with severe levels of poverty. But to acknowledge the fact that we continue to see racism within these populations, I think, is incredibly important. And so to emphasize racial justice is just as necessary when working with these populations as it is with any other population. So, so far, 28% of our vaccines have gone to people experiencing homelessness. 44% of our vaccines have gone to staff or volunteers. That is another significant disparity that we are currently working on addressing. Moving forward, our hope was in the next week or two to start using J&J vaccines within our clinics, given by our clinic staff. It is still our hope that we're able to move in this direction, but obviously the use of Johnson & Johnson is on hold at this point due to the guidance from the CDC and the FDA. So to be continued on that. Staff and volunteers are now being diverted to the greater Hennepin County vaccine efforts instead of utilizing the vaccines that go through our program. This is partially because vaccines will be given out in our clinic settings, and our clinics do not serve staff and volunteers. So, and then additional equity efforts are underway at the individual clinic level. This includes a robust effort to provide support to people who are working in those clinics to emphasize equity, diversity, justice, and inclusion, and to continue our commitment to our patients to monitor equity data and to utilize that data to emphasize justice in our efforts. So I want to just show, next slide, just a few of our stats from our dashboard. We actually created back in January a dashboard to help us track equity and track our numbers, with the idea that if you are not tracking equity, it's very difficult to maintain equity because our system will revert to a system of oppression if we are not monitoring and then reacting. So this is just a map of where we are so far. You can see there our doses of Moderna, our doses of J&J. This is updated at least once a week, oftentimes far more often than that, and the locations at which our vaccines have been given out. We continue to work on second doses of Moderna and see that challenge in terms of getting 2 doses for people as opposed to just a 1-dose vaccine. You can keep going. Next slide. So this I just wanted to very briefly talk about. This is our the main page we use to track racial equity. As you can see on the bottom left-hand corner is an estimate of race and ethnicity of our clientele. This we are able to break down by our clinic sites and just gives us a picture of where we are at in terms of our shelter sites. Just this information is very difficult to track because of the transiency of our population. So this is an estimation, an educated estimation, but one nonetheless. As you can see there, the Black population makes up about 46.2% of our total overall population of the sites that we've been serving with vaccines. And then on the greater picture, you can see there that we have given 1 dose of Moderna to about 39%. 39% of our doses have gone to people who are Black, and about 32 complete series to people who are Black who are experiencing homelessness. And so you can see the disparity there. I also just want to note the overrepresentation so far in people who are recorded as white in this population as well. So, and that is all I have for my part. Thank you.
Thank you, Naomi. We're going to hear now from John Adams, director at Harbor Light Shelter.
Hey everyone. As Katie said, my name is John Adams. I'm a social worker and the program director at Harbor Light Center. I'm excited to be here. So my part really was about the operational part of it. We focused on location, support staff, and information, and how that information was received and then communicated to all the other organizations and the clients as well. We had 3 driving considerations regarding this. We were always had equity in our forefront when we were discussing how we were going to set this up and what it was going to look like. Because equity for us really equaled accessibility. So we were kept thinking about, okay, what does accessibility look like to our population? We also then would consider a shared understanding. Are we working with the shared understanding between organizations? Because we were sitting here working with 3 different organizations and 3 different ways of speaking and talking and 3 different ways of acronyms. So we wanted to make sure that we had a clear understanding of what was expected. And then the third was empowerment. We wanted to make sure that we were supporting the client in making an informed decision. Not lead them one way or another. We just wanted to make sure that we were informing the client while making an informed decision. So the first component of this was the location. We had to figure out where that was going to be. We set up in our chapel. We were fortunate enough to have a huge facility that's co-located within the shelter. And we had to have, there were 5 stations that we had to set up. We had to set up check-in, we had to set up registration, we We had to set up the info check with the community health workers. Then we had to set up the vaccination stations, and then we had to have an observation site for the clients to sit for about 15 minutes. So again, with the driving considerations, we wanted to make sure that the client was supported through every step of this process, right? Which means we reached out to staff, support staff, to make sure that if anybody had questions along the way, they were there to support them. So we intentionally chose case managers to help facilitate the process with the clients. I'm not sure if you guys have seen the registration forms or not. It's about 3 pages long, and it's all medical terminology, right? So to expect the clients to read through this and understand it, we wanted to make sure that we had a staff that could translate what that information was, so that, again, that the client could be informed about what was going on and what was happening. And then it all kind of like links together, because most of the information that our staff got started about a month prior to our first pod, and that had interaction and support from Healthcare for the Homeless on meeting with the frontline staff and informing them, hey, here are some talking points. Here's what the registration form looks like. Here's what it means. This is how you can translate that information to the client. That was incredibly, incredibly important. And like Naomi was saying too, that the relationships that the staff had built with the clients was incredibly important. So because our staff directly reflects the clients we serve. So I think that was incredibly important. But again, there was no push toward, yes, I think you should do this, or no, I don't think you should do that. It was really about empowering the client to make that decision on their own. There were just talking points. It was very conversational. I was incredibly proud of our staff. So that was really important. And then the third part about it was the information, how we can translate this information and make sure that we had a shared understanding between organizations, between staff to client, between staff and medical staff. So it was incredibly important to have that collaboration as well. We wanted to make sure that information was accessible. So once we got that direction from information from Healthcare for the Homeless, we then thought about, okay, well, we're posting these signs everywhere, right? And it's in 0.5 font, and it's 3 pages about, okay, this is why you should take the vaccination clinic. Come to the vaccination clinic and get vaccinated. Well, you know, we're assuming that the majority of our clients have high literacy rates, correct? So we thought about, again, accessibility, and we thought about, all right, is there another way that we can translate this information to the client and have the client access information? So we were given some resources, some videos from the Minnesota Heading Home Alliance that discussed equity and the vaccine. And we then set up times where clients could sign up to go to the computer lab to actually watch these videos. So yeah, and that actually was helpful for some of the clients as well. So yeah, we wanted to make sure that the space itself too was trauma informed, right? We here in Minneapolis, we were doing our first pod in February. So it was like 5 degrees out there, and we all had, you know, layers of clothes on, and there was that understanding that we were asking people to take off some clothes. So we wanted to make sure that we had some separation between the population, everybody who was attending the clinic, and then the medical, where people were getting vaccinated. So we had partitions set up so that people would feel a little more comfortable. And so to get the clients to sit for that last 15 minutes after they got vaccinated, most of the clients are like, all right, I got vaccinated, I'm out of here. We incentivized it a bit by providing food. So we would, and conversation. It was really cool to see the clients kind of hang out and not feel burdened by hanging out there. It was really wonderful to see a true collaborative effort between all the organizations and then really supporting the client. It was very client-centered. It was a great, great experience. Our signage did change from the first one to the third one. I believe that even within the stations that I discussed, we kind of made it less formal. I think for the observation section, I think by the end of the last pod, it was like, hey, sit down and have some food for 15 minutes. We wanted to really adjust the language, which was first like observation, which was it was a little too clinical for us. So we thought, hey, why not change it to meet the needs of our clients? So all in all, it was wonderful. I think we had started and set the expectation, at least from our staff. We had ongoing conversations about being client driven and making sure we were supporting the client and the other partners as much as we could, because we didn't want to be a barrier to other people, for people actually receiving the vaccine. So yeah, this was a really very positive experience.
Thank you, John. And now Veronica Jackson, who was described to me as community health worker extraordinaire. And when you see the amazing work that she did, you will agree with that sentiment. Veronica?
Hello, everyone. My name is Veronica. I am a certified community health worker. And prior to my work at Hennepin County, I worked with the unsheltered population in behavioral health. So everything that I was pulled in to do with healthcare for the homeless just kind of made sense. But I will start by kind of giving you a little background of kind of where we started and then where we are now. So I work on a team of community health workers that are a part of the COVID-19 response task force. Our particular section started in August, and so we have been leading logistical testing throughout Hennepin County since then, really. So that's leading day of sites for testing, and then also doing all of the logistical background work, all of the outreach for those particular events, both in the larger community for Hennepin County and also long-term care. So we partner with Hennepin Health and MVNA, which is the Minnesota Visiting Nurses Association. And they handle all of our kind of like clinical work. So the nasal and oral pharyngeal swabs, the nurses that come from MVNA administer those. And then the Hennepin Health Lab processes all of our tests. So now that we've kind of been focusing really heavy on the vaccine pods, so like our points of dispensing, Hennepin Health and MVA nurses, they do all the vaccines at the pods, including the healthcare for the homeless pods, until healthcare for the homeless kind of takes that over back into the clinics. And so in the beginning, the nurses, they bring all of the registration forms, all of the emergency use authorizations, and then they're responsible for determining like if an individual can get the vaccine at the pod or if they need to check in with their doctor. Next slide. And so where I come in, I was asked to kind of take over the comfort kits that we give to people experiencing homelessness after they get vaccinated. For those of us who have had the first and second dose, depending on your body, we know that reactions are very different from person to person. And so the whole idea of these kits were to alleviate some of that discomfort that, the vaccine could potentially cause. And so in the comfort kits, we had like the warm compresses. And so these are just kind of like the hot packs that they give you in the doctor's office. One of the things that we found for those of you who are going to start making these kits in your towns is that when it gets really cold, so in Minnesota, we were dealing with some like -30-degree weather. If they freeze, they don't work so well. So keep that in mind. Electrolyte powder, we want people to stay hydrated. We had dry soup mix, tea bags, just to really kind of help people with the comfort part of it. And the reason we had the cups and the spoons, some of the people that we were working with who were experiencing homelessness were in hotels and shelters. And so a lot of the people had access to hot water, but we also vaccinated in places where people had campfires accessible. So we provided the cups and the spoons just to make sure, like, if they had access to heated water, they had something that they could actually eat and drink out of. Socks, hand warmers. We found out that when the warm compress didn't work in those really cold temperatures, the hand warmers, like hot hands, they work really well. So, and they last longer. And then knowing that we're still in a pandemic, whether you have a vaccine or not, you still need to wear a mask, and we need to practice good hand hygiene. So this is an example of the kits that were made. Everything fit in a really nice gallon-sized bag. So you throw everything in a gallon-sized bag, and then as people are coming out and waiting their 15 minutes in observation, you can just hand people a bag. It's a lovely COVID-19 party gift. It's what we ended up calling it at some point. And so how this worked is after we got done packing, we received a list of the places that we were vaccinating in, and then trying to figure out like how many doses we would have. Then that was the number of vaccine kits that we would bring to each site. So the community health workers that were working those particular events would stop by our command center, pick up their boxes for the day or the next couple days, and then bring them to the site we were vaccinating in. Prior to us doing that, we heavily relied on our medical director, Dr. Robert Shaw. She was kind of like carting things around in her trunk. And so it was kind of nice that we were able to take that over. And then this is one of our mini packing parties. Typically we set it up so there's anywhere between 5 or 10 of us on days that we don't have pods. and we just kind of sit in our command center. We lay everything out, and we're able to get done 200 kits in about an hour and a half. But then that also depends on how many people show up. So here with 3 people, 200 is easy to do. If you are working where you are alone, obviously it takes a little bit longer than that. But yes.
Thank you so much, Veronica. Thank you all. And just absolutely amazing work that is being done there. I am conscientious of time, so I wanted to ask everyone one final question. What changes have been made within your organization and crossing in your collaborations that you hope or plan to make permanent or to extend past the pandemic times?
I think for us at Harbor Light, I think it's really incorporating equity into our culture and really asking what that means, right? Yes, we all can sit here and talk about equity, but what does that mean, right? And how are we going to apply that? And how does it show up? That's what we took from this experience is, all right, we're not doing our service. Yes, we are supporting the client and giving them a place to sleep, but we could do better.
And just to piggyback off of John, yes, I think ours is very, very, very similar. I think we measure what we care about. And I think that is one of our biggest lessons, is that measuring equity is our responsibility. That is part of our work. It's not an addition and it's not an option. It is part of how we provide care to our patients, and we need to be held to those standards.
And I would say kind of the state playing a more active, assertive role in communicating to homeless service providers and congregate settings about, public health, and also providing, resources and coordination. And then Blair's got hers in the chat since she's still in the car. Learning from our partners and from people impacted by homelessness, where we should focus our work and support the work of our local partners.
That is wonderful, and certainly an important note to finish our time together on. So thank you all again for engaging in this conversation and sharing with us your experiences. I am so grateful to all of you for the work that you've done and that you're sharing it with us. Just a few closing notes. This, as I mentioned at the beginning, this webinar is the second part of a 3-part series featuring health center collaborations with their local jurisdictions. We have one more on Thursday, April 29th, 1 p.m. Central. There is also, the council is also doing a 2-part series on trust and trustworthiness, starting on April 21st, and then the second part on April 28th at 1 p.m. Central. And all of the amazing providers that we have an opportunity to interact with have been providing us with on-the-ground information of what it has been like to do vaccine rollouts. And we share that information in our bi-weekly flash blast. So please, I welcome you to sign up for that. And then this coming Monday, on Monday, April 19th at 12 Central, we will have a community discussion about opportunities that could arise for health centers regarding the HRSA's new funding that is becoming available, and that in many areas is available, and opportunities for thinking beyond COVID and how we can really transform the work that we do regarding caring for our patients. And then finally, the National Healthcare for the Homeless Council has our annual Conference and Policy Symposium coming up May 10th through the 14th. It is a virtual symposium this year. Welcome you all to join us in that amazing opportunity. 5 days, 3 days of regular general conference filled with presentations from collaborations across the country featuring health centers and the work that is being done, not just in COVID work, but in all areas and aspects of serving people experiencing homelessness. Thank you all. It has been a pleasure to have you here with us, and we look forward to seeing you again in future sessions. Have a wonderful afternoon.